Today I am speaking. I'm Stacie Christian. I'm the interim director for the American Intercultural Center, the diversity director, and also Dr. Vespia is here too, and she'll introduce herself when she's up here in the limelight. In the meantime, we're glad to have you here today. This will be the last one of our series this semester. We will certainly have plenty more next semester. We're going to start off in the fall talking about First Nations, so we'll move forward in that regard. Today we're talking about understanding anxiety. Diversity was my last presentation. Today we're talking about understanding anxiety. And the interesting thing about anxiety is that every one of us in the room certainly can say that we've experienced anxiety. Typically, of course, even if we're starting late today, we can even have a demonstration on stage, but I think we're doing all right. But most of us have an understanding of what it feels like to be anxious, but some individuals have a greater understanding of what it means to be anxious in a way that it affects their daily ability to do things for their work or maybe for their family. Primarily, when we see students on campus or workers that are anxious, it's something that's more temporary. It's not something that's more permanent, though. When we look here, there's two variations in anxiety, and one is, of course, life transitions, and every one of us has had that. Maybe you've been working on arranging for a wedding, or you're starting a new job, or you're taking a child to daycare for the first time, or starting a new class. Those are things that might make you anxious. We also have something where it's more of a condition, is something that's diagnosed for the DSM-5 by a licensed provider. And today we're going to talk just a little bit more, maybe not so much about the diagnoses, but more about how anxiety affects us on a daily basis, but I'll give you a little more information here. Anxiety disorders are highly treatable, although there's only about 1/3 of individuals actually seek treatment for anxiety in a way that they feel that it's affecting them enough in their daily life that they want to go and get help from a professional. Nearly half of individuals diagnosed with depression also have a diagnosis of comorbidity of anxiety, so it's something that's fairly common. Statistics in the United States, there's 40 million people, 18 and older, who might experience anxiety, especially affected this year, that it might impair their life, and also 4 million people will be treated, so it's, again, a large number of individuals. Stress combined with anxiety can increase drug and alcohol abuse or use, and some of you may identify, we're certainly in a stage where we do a lot of binge drinking. We're known for that in Wisconsin. And I certainly hear individuals say they've had a tough, stressful week, and they're going to go home and they're going to have a drink, or someone will say, have one for me, or all the sayings that we have. So certainly you're familiar with the concept that people will use alcohol to help decrease their ability to feel anxious. Some individuals, we have students that talk about this too, you go out and you're socializing, they'll start having a drink to feel comfortable when they're out socializing with people they don't know yet. They use it as a sedative in that way. And so you certainly understand how anxiety can be affected by drinking alcohol. Paxil and Zoloft are the most common anti-anxiety medications, and of all medications that are prescribed, they're number 7 and 8, so you can tell that in society we have a lot of individuals dealing with anxiety. I have types of anxieties with diagnosis. These are for individuals that have anxiety enough that they need to go have treatment through a healthcare provider. Phobias are the most frequent. There's 19 million, which is 6.8% of the population. If I actually poll the room and ask how many of you have a phobia, how many are afraid of snakes, worms, bats, every one of us has something, right? Snakes, how many of you hate snakes? Usually it's men, but we've got a couple women out there. How many of you are afraid of heights? You get up there and your knees start shaking. Okay, you got that. How many of you are afraid of driving on tall highway bridges, say, okay, Tower Drive, all right? All of those, and that would be me. I'm not driving over Tower Drive. If you see me driving there, you know something's wrong. So some of those things will really get you to be anxious, and you get that, you understand that. But for some people, a phobia might be so extreme that they're afraid of touching other people without hand washing a lot. Sometimes it's more obsessive compulsive, but they might be more afraid of maybe speaking in front of a large group of people, and they get nervous and start breathing differently. Those are things that you might experience also. Generalized anxiety disorder is very more common. There's 6.8 million adults, which is 3.1% of the population. I'm sure there's people in the room who have been told they have generalized anxiety. That's not unusual. Social anxiety is very common. That's 15 million, 6.8% of you might feel like you're feeling anxious in society. Panic disorder is something that sometimes when people have it, they feel like they might be dying or passing out, or they might be having a heart attack. And we've had students sometimes have panic disorder before exams or panic attacks before exams. You might have a panic attack driving over Tower Drive Bridge if you don't like driving over that. If you get in a place and you get nervous, I'm sure there's people in the room that have felt the experience of having a panic attack too. In post-traumatic stress disorder, there's 7.7 million or 6.8% that have this experience. Now some of this is a little basic here, but I just want to give you an idea of what the face of the individual might be who's experiencing anxiety. There's a higher risk factor for girls that smoke, higher risk factor for girls who start puberty earlier in life. Women have anxiety diagnosis more often than men. Individuals who have a family history of depression or anxiety are more likely to have generalized anxiety disorder, and generalized anxiety disorder often starts in their 20s, which makes sense for you if you're working with school, if you happen to be a faculty, but even if you're staff and you're working with student employees. 20s is kind of a big time where there's a lot of change. There's a lot of stress going on. So you have a little more anxiety during that time. Once you get more used to your life and how it's going, I always tell the students it usually gets better. You can start relaxing a little bit later. You feel more calm if something's happening. It's like it's no big deal because you've had it happen before, you know. So you get used to it a little bit. Other risk factors for social anxiety, I'm just talking a little bit about this because Dr. Vespia is doing more in the multicultural perspective. But some other risk factors, if you have a Native American ethnicity, low income, life stressors such as health or family problems. It reduces risk for social anxiety. Actually, if you're Asian, Hispanic or Black, or living in a populated area, research indicates that that's a little lower. There's other challenges. Cultural factors that affect anxiety, race stress increases stress for non-Hispanic white, Afro-Caribbean, and African American. But discrimination based on race increased anxiety risk in African Americans. So culturally, we each have a different effect on what's going on in our environment. And maybe you're going to be addressing that a little bit more too, so I'm not going to get into that. So signs of anxiety, first I want to talk a little bit about the myths, because I hear a lot of these things. Medicine's the only treatment that works. Sometimes people think that they have to get medicine for anxiety, so they say, I don't want to go get medication, I don't want to have an anti-anxiety prescription, so therefore I'm not going to go in and get help. And actually cognitive behavioral therapy is one of the ways that we use when I was out working as a clinical provider in the community. Many people came in and had cognitive behavioral therapy treatment, and they were able to reduce their amount of anxiety. They relearned how they were thinking, and so they didn't have to have medication. Other people may have medication while they're doing cognitive behavioral treatment, behavior therapy, and other people may, avoid it altogether. So it's not a guarantee for you. Often people say they're afraid they're going to pass out when they're having a panic attack, and our medical providers always said that would be so improbable. Typically, when you have a panic attack, you feel the breathing coming in, and people feel lightheaded a little bit, and their vision kind of intensifies in a different way, and so they feel like they're passing out. It's their perception they're passing out. Reality is your heart rate's picking up, and you're going to pass out more if your heart rate goes down than if it's picking up. So the odds are that you're not going to pass out unless all of a sudden you stop breathing entirely and hold your breath. But typically that's not what one does. So when people are having a panic attack, we like to talk them through it and say, no, you're not going to be passing out. Your heart rate's increasing. Work on decreasing your heart. There's some different things that we talk to them to help them to relax. We have them to breathe more slowly. We have them count to 10. They used to throw a paper bag over their head, and we don't do that anymore. You've ever seen people walk around with a paper bag and they're breathing in the bag? We don't tend to do that anymore clinically. We try to teach people to do it all in their own minds, to try to teach yourself to think about something that's relaxing, count to 10 slowly, and then also just start breathing a little differently. Another thing that you might have heard about is we used to be giving people rubber bands more in the 90s to put around their hand, and you say, if you're thinking about something, snap that rubber band, We don't do that anymore. I haven't seen a therapist do that in a long period of time. Typically, they said there's a better way, and it's more like retraining your thinking again rather than me snapping this rubber band. Part of the thing is when you're doing these things like breathing in a bag and snapping a rubber band, everybody's noticing you, which increases the anxiety. So we're trying to teach you ways to decrease the anxiety without a lot of people paying attention to you. If you're an anxious person, they used to do this more in the Victorian era. They always thought women were going to be passing out all the time and anxious as nature and character. So they would put us in quiet rooms with fanning couches and relaxing. And so it reminds me of some of the era when my grandmother talked about those things. But essentially, if you're an anxious person, it doesn't mean you have to remove yourself from everything. Essentially, you want to still participate in things. You maybe want to bring a friend with you if there's something there that might make you anxious. But we don't tell people anymore to leave the area, and you should still participate in life. I already talked about the paper bag, so I don't have to worry about that. So differences between anxiety and anxiety disorders. Now, anxiety, again, is something that every one of us has. Anxiety is a biological response that our body's telling us, remember, you need to know something about this. So if you've ever had a panic, like if you're, and I'm trying to think of something even better than that, but if you're ever thinking like all of a sudden your child is near you in a store and they disappear and you can't find them, and you get that anxiety and you panic, well, it's a good thing because your body's telling you better go find this 2-year-old or wherever they're running around. They're usually right in the middle of a rack laughing at you, when you're running around. But, they're usually around there. But anxiety is there to tell you that you need to pay attention that something here has been a problem before, or it could be a problem. So anxiety in itself is not a bad thing to have in our bodies. It actually helps us to cope and prepare for things that we need to do. But an anxiety disorder interferes with daily activities. You think about something all the time. I had a coworker years ago that constantly worried about the fact that they might, I don't know why he worried about it so much, but he worried about the fact that he might be walking around with his fly open all the time. So he was constantly obsessing about his fly. So you'd see him turning around, checking his fly, he'd go in the corner, he was checking his fly. And he always, and one day his boss said, why don't you just wear sweatpants to work? You don't have to worry about it. He was trying to tease him, but it didn't help him any. It was something he really worried about. He was very compulsive about the fact that his fly might be open. And so that's what he thought about. But other people might think about the dread that maybe someone's going to ask him to do a presentation, or maybe someone's worried about the fact that they might have to answer the telephone. There's people that have telephone fears of answering the phone, or they're going to have to talk on the phone to someone. Or there might be anxiety that you have about people are afraid of elevators and getting stuck on an elevator. And I have a claim of fame. I was stuck in the elevator at the Coffin Library when I was pregnant many years ago and had to get pulled out above through that. But, you can get stuck on an elevator, but most time you will not get stuck on an elevator. Managing anxiety for college students, I have a little bit on this, but I'm going to move off of that because I'm going to get Dr. Vespi up here too pretty soon. But for college students, and if you're working with college students in the work environment, it also works similar to what it is in the classroom. That's why I have this up there, because in some ways it's similar. And college students need to talk about their anxiety with others. And actually, it's for all of us. That's the same for any age. If you have an anxiety, you should be able to talk about it. We used to, even in the 1980s, I recall being somewhere and a therapist was saying that his focus was that when people were anxious, they should not talk about it because it just made them dwell on it more. When you look at some research and talk to clinicians now, there's some way that if you want to avoid something, if you're dwelling it all the time, you want to not think about it. But for the most part, if you're dwelling on something, you have to think it through, talk it through, and get it out of your mind, or it's still on your mind. You know what that's like? You try to suppress something, you maybe even dreaming about it at night, or it comes across your mind when you're anxious and it comes out again. So at this point in time, many of the clinicians that I had worked before, and they talk about the fact that they try to get people to actually talk about it. They feel that talking about anxiety actually decreases it more than covering it up. Now, if you're obsessive compulsive and you're talking about something constantly, then there's a different way to treat that. But just generalized anxiety, when you just worry about things, you should be able to talk through that. 62% of students who withdrew from college did so for anxiety disorders, according to what the recent research is. And test anxiety affects us in different ways, too. And you talk about this a little bit, too. How is this similar to your workplace, how you feel when you're anxious? Do you have fear of failure, that you're going to be up in front of people talking and you're going to make a mistake and people are going to say, oh, man, she doesn't know what she's talking about, Or you submit a major proposal and it doesn't get accepted in the way that you want to. How is that unlike anything that we experienced in college? It's very similar in many ways. It's just that we're doing the big job now, and before it was maybe you're going to get a grade for it and be more, maybe sometimes accepted more for making mistakes. But it's very much the same. We have fear of failure. Maybe we're not prepared, maybe we're overscheduled. I can kind of relate to it. We're kind of teasing that I've been up here talking about anxiety because I've been overscheduled lately. Some of it I've done myself, obviously, because I say yes. And so you have all these things that you're scheduled, and you have to be prepared, and then sometimes things happen. A flash drive cracked one day when I was doing a presentation. I had to do it without the flash drive. Whenever those things might happen, you have to be prepared to think, what is the worst case scenario? So what's going to happen? I think part of being in healthcare, the worst case scenario was that somebody might die. If I show up, my flash drive cracks, I'm not going to die. You're just going to say, well, can't do it today, go home, or listen to me ramble in a different way. So you have to think, how critical is this? How important is this that I'm so worried about this? Most of the time we're worried about things that really we're just making it a little worse. And sometimes we do have things to worry about, but then we have to take time to think about how we're going to work with that. Prior test history, if we've had bad experiences before, whether it's taking a test, whether it's doing a presentation and we didn't do well, you will certainly have anxiety with that, and it can compound your ability to go forward. So these are test anxiety symptoms, but frankly, this fits a lot of things. You can have a headache, nausea, diarrhea, excessive sweating. Sounds pleasant, doesn't it, when you're sharing a cubicle with somebody that's having that? Shortness of breath, rapid heartbeat, similar to a panic attack. Sometimes people feel that they have other things going on. In reality, they're having issues with anxiety. Emotional symptoms, they might have issues with anger, helplessness, fear, disappointment. Any one of those things can be adding in there. Behavioral cognitive, they might always think negative. Sometimes people that think negative, I think it's because they're afraid that there might be a loss, and they're at a level then where they feel they can be at if there is a loss. If they didn't get what they wanted, they don't feel like they have to be sorry about the failure or feel bad, but they can be happy if they had a gain. And it seems like that moderation in the middle can kind of add to that, where they're thinking negative. It makes people feel negative around you, and it kind of makes other people anxious too. Commonly compare yourself negatively to others, and certainly poor concentration qualifies in there too. So I'm going to do a little bit of this and to make sure that Dr. Vespia has time too here. But managing test anxiety or any anxiety is very similar. You have to be prepared. So if there is something that makes you anxious, what are you going to do for the backup plan if you can't follow through? Or if it's because you're anxious because you're not always prepared, then take the time and get prepared. Have something done ahead of time. Don't try to do everything last minute. Our society has become much more procrastinators because it seems easier to do some things in some ways. We can do web searches quickly. We can do, have people help us more quickly. I was kind of talking to another cohort here, and when we used to take exams years ago or write papers, they told you at the beginning of the time, and you had to wait. You even had to order your papers to come in so you could write your papers, and you're typing on a typewriter, and all these things you're doing. Today, we can do things faster, quicker, and in some way that adds to our anxiety. It just makes things go faster, quicker. We expect it to work. If it doesn't work, then we're in a panic. You can also be positive, stay focused. We have to work on healthiness, and on campus here we have Healthy Choices in the wellness program that we can work with. We got the Crest Center. Any one of those people will be happy to talk to you about how to make better healthy decisions in your life. And we have a counseling center, of course, on campus too. And I'm finished through this, and then I'm going to let Dr. Vespia talk a little bit. Again, I'm going to be emailing all of this to you too, so you'll have it later. And what I think you need to do most for creating an opportunity to deal with anxiety at work is to really have a support network. And sometimes we get ourselves in a routine where you're working with the same people all the time. And I think one of the benefits of coping with anything that might make you anxious or if you feel overwhelmed is that sometimes people just have themselves a little too pigeonholed. They don't have enough support around them. They don't have somebody they can go to and talk to. They're afraid to ask for help. And there's really, every one of us in this room has had a time when they feel like something was just a little out of our realm and we needed to get someone to talk to. And so you want to make sure you have a couple people that you can talk to. If you find you're talking to people daily, weekly, maybe there's something else you need to do, because people shouldn't have to have that every day, have you come in and say, boy, I'm having a tough day and going on and on. Maybe you need to go talk to a counselor about some coping skills or work on making some work habit changes. But for the most part, certainly checking in with people once a week, once every few weeks, that should be okay, as long as that's enough to help you to manage your anxiety. You want to make sure to set more smaller daily goals. Sometimes the goals are very big and there's a lot and you can't quite accomplish all of those. Other individuals want to be very perfect, and things have to be very perfect for them. And if it isn't perfect, they're anxious about it. And so that's an opportunity for us to realize, too, that we are allowed to make mistakes, that people can even be humorous about that sometimes, too, and people aren't always critical if you make a mistake. So these are some other things, but I want to give Dr. Vespia time to talk here. Are you okay? You all right? I'll take a couple more minutes to finish my thoughts then. Another thing that you can do at work is make sure to take time to distract yourself. To make sure to have time that you're not just working intently on something a long period of time, but that you actually take time to go for a walk. Maybe you can run a paper yourself and go down on a walk, and then you can even see the environment looks a little different. Or during your lunch hour, and I see more people doing that here, they actually gather up a couple groups of people. It doesn't even have to be people you work with every day. It might be better if you're going with people you don't know, and go for a walk through campus and come back again. That can be very helpful. Pardon me, goodness. And then the other thing is that to make sure that, again, that when you're working with a team, that you take time to talk to each other and talk about what is something that's your best skill. What are you good at? What is somebody else good at? If you have a project you're working on and you talk about it ahead of time, and you have the ability, sorry, now I'm losing my voice. And you have the ability to talk about what this project is, who has the greatest talents, that can be very helpful and can empower all of you. It's always a good thing when you have a team to take time every now and then to talk about, this is what my skills are, this is what I need to learn. If you do that ahead of time, it helps decrease anxiety later when the crunch time is there with a project and you have to get together and work. If you've been pretending you know how to work on the computer as well as anyone else, and it gets down to crunch time and you can't figure out how to use it, it's not going to go well for you. Or if you've been telling people, yeah, I can do the presentation, but you get up front, you really know that you do bad at presenting, and maybe you would be better doing some back end, that's better if you talk about that ahead of time. The part of the anxiety in the workplace is making sure you have a very effective communication with your staff, that you know who has what skills, who needs to have future skills, and you work on that as a process rather than as a last-minute stopgap. And that is it for me. So I'm going to have Dr. Vespia come up.
At any rate, I know, gosh, most of you in this room, but I don't know all of you. I'm Chris Vespia. It's very kind of Stacie to call me Dr. Vespia, but really Chris is what everyone calls me and what I would hope you would. I'm a faculty member here in Human Development and Psychology. I am a licensed psychologist. I don't currently practice. I have another full-time job, but I am a licensed psychologist, and I do teach classes relating to counseling and psychotherapy on campus. So I teach our counseling and psychotherapy class. I also teach a class called Multicultural Counseling and Mental Health for our undergraduates on campus. And I have some, I will not claim in any way, shape, or form to be the world's most expert on these sorts of issues, but I think part of the reason I was asked to be one of the speakers today is that I've also done some scholarly work in these areas. So I have a book chapter coming out in this next year related to suicide across cultures, and I had one from a couple of years ago looking at schizophrenia internationally. And so those sorts of things are really of great interest to me as much as anything. But with that having been said, what I really want to do is talk a little bit more about anxiety within cultural context. And I wanted to start out with actually a very brief first-person account. It's relevant to the presentation, but it's also a college basketball player. So for those of you who are following the NCAA tournament, you're going to get your the fix on that as well. Do we have volume? Would be my question. Okay, never mind. It was a really great idea. It's a great clip. I'll send you the link. It's wonderful. But hey, volume is overrated. So Royce White, for those of you who do not know who Royce White is, was a basketball player at Iowa State University. And what he actually talks about a little bit in this interview with the Des Moines Register is his experiences with anxiety. He ended up being drafted by the NBA, was a first-round draft pick, and he got suspended from his NBA team in part relating to his issues with anxiety. So this is actually a clip where he talks about his experiences as a college student with that anxiety, but one of the issues that came up for him was that flying to games was a real issue. And he ended up being suspended from his professional team as they tried to negotiate accommodations in the workplace related to this, and essentially ended up in a dispute over whether this was a reasonable accommodation in some ways. But at any rate, the clip, I think, is helpful for a couple of reasons. One, because you get this first person account of just how disabling anxiety can be. And that, in fact, not only is this a diagnosable mental illness, but it is something that oftentimes could qualify you, depending on the circumstance and what the issues were, for accommodations, whether those are accommodations for our students through disability services in terms of extended test-taking time or distraction-free environment, things like that, or whether those are other sorts of accommodations within the workplace. So I think it's important to know that. But he also goes on to talk a little bit about how one of the ways that he's approaching his anxiety is through his practice of meditation and wanting to learn more about that, and that being related to spiritual practice and cultural sorts of beliefs. And so I think that's an important piece of that as well. So anyway, the clip would have been shorter than listening to me explain it, but that's neither here nor there. Okay, now I have my clicker. All right, what are the sort of key multicultural issues that I want to talk to you about? This is really going to be a very quick overview of what is a very complex topic, but some of the ways in which culture can end up interacting with mental illness in general and anxiety more specifically is in how normal and abnormal are defined within cultural context, the way that symptoms are experienced by the person or expressed, beliefs about causes of the anxiety or the mental illness, racism and discrimination, which Stacie alluded to, and I'm going to get into a little bit about as well, the protective factors or coping mechanisms that exist for the individual with anxiety, and also perspectives on seeking help and how that is viewed and what sources might be considered appropriate or acceptable within that as well. So let's just deal with each of those individually. What is normal and abnormal is very much a social construction, okay? So, mental illness is something that is, it's something that we define, okay? But how we define it changes, and it changes based on context, and it changes based on culture, it changes based on time. So there are things that are considered mental disorders today that may not have been 50 years ago, okay? But there are also things that were once classified officially by the American Psychiatric Association as mental disorders, such as homosexuality, which are not defined as mental illnesses today. Okay, and so I think it's really important to remember that we have to consider those sorts of things. So, for example, dependence. In the United States, if we were to have, in many cases, an 18-year-old, a 19-year-old, a 22-year-old who were to come to us, if we were to have a non-traditional student who were in their 30s who would come to us, and let's say this was a single person who was trying to decide on a major and said to us, well, I've got to check with my father first before I declare this. There may be an inclination for the person who is their advisor to say that's inappropriate, that's pathological dependence. They shouldn't be checking in with their parents. They're an independent adult, and they need to make this as an independent adult decision. That may be true within the context of an individualistic culture. Okay? That may not be true within a more collectivist culture where many of those decisions are made with the welfare of the community, the tribal nation, the clan, a variety of other things within that decision-making structure, or where it would be inappropriate, for example, for an adult unmarried woman to live by herself as opposed to continuing to live with her family. And so all of those things have to be considered. Normal cultural mistrust. The same behavior may be viewed very differently if you have an employee or a student who is coming to you and saying, you know what, the police, they're always watching me. Is that a sign of anxiety? Is that a sign of paranoia? Well, does it matter whether or not this is a young black man who lives in an urban area where the police really are watching him pretty darn closely? You know, how much anxiety is normal to experience when you're alone at night in a parking lot if you're a woman versus a man? And I don't mean that as a judgment on the ability of people to defend themselves. I mean in terms of statistical risk. Okay, how much potentially risk is there in that situation? Hypervigilance, when we talk about veterans, for example, on our campus, and when we talk about individuals who've been in the military, part of military culture, particularly before one is deployed to a war zone, is going to be to train someone to be hypervigilant. Because for them to be aware of their surroundings at all times and to jump, literally not to jump, but to have the reflex to do something immediately if they're hearing a twig snap, they have to do that to survive, okay? In a college environment, that is actually going to be counterproductive. Okay? But it's not like that training just goes away like that, okay? So I think we have to be aware of some of those sorts of issues that may come up. In terms of symptoms and diversity, in Western cultures, to use just, I'm going to speak in very broad terms here. In Western cultures, generally speaking, the mind and body are thought of as distinct. Okay, and so we talk about mental illness and physical illness as different things, and that makes sense. Okay, however, in many cultures, in more Eastern cultures, in many indigenous, native cultures within the United States, the mind and body are seen as one. And there's not that distinction made between psychological and physical pain. And so in many cases, there's good research that would say, for example, that for many Asian individuals, the symptoms of anxiety, depression, other mental illnesses that they may experience are more likely to be physical than emotional. So they may not be as likely to say to you, I'm feeling anxious, I'm feeling sad. But what you may get instead is difficulties with migraine headaches, chronic indigestion, muscle tension, sleep difficulties, things like that. There also can be cultural and gender norms against displaying certain behaviors or emotions, right, where it isn't going to be considered appropriate necessarily, and the person may not realize this consciously, but for example, we know that women tend to be diagnosed more with depression than do men, and there is certainly some research that would suggest that women may suffer from it more than men, but a piece of it is also we wonder about the accuracy of diagnosis. And folks have been talking more about a phenomenon known as masked depression, where men, for example, may be more likely to complain of symptoms of irritability or anger or physical sorts of symptoms and manifestations of depression, and may be less likely to be diagnosed accurately, not so much less likely to suffer. Okay, so those are things to think about as well. When it comes to causes of mental illness, and I'm just going to sort of race here a little bit. When it comes to causes, really interesting study that was done with participants from China and the United Kingdom, where they asked them about just a general public sample about causes of schizophrenia. Overwhelming majority of responses in the UK were that it was biological, genetic, brain structure. Okay. Overwhelming responses in China, somehow related to family discord or child abuse. Okay. I'm not saying that the factual of that, okay, and for many mental illnesses, they are multi-determined and we don't actually know precise causes. We certainly have good biological evidence for schizophrenia, but it's not as though it's clear cut, okay? The factual of this doesn't matter as much as the perception. Because if what I believe the cause of my anxiety is, or what I believe the cause of my depression is, for example, a spiritual problem, not a psychological one, then I'm going to seek out a spiritual source of help, not a mental health professional. Okay? If I believe that my problem is a biological one, I am more likely to want medication as a treatment than therapy. And so it does have ramifications for the sources of support people may seek out. Some other just examples: Aboriginal Canadians, many individuals will talk about supernatural causes like taboo violations as causes of mental illness. For traditional Arab religious leaders, they talked about 3 causes of mental illness: evil eye, evil doing, and demonic possession. Traditional Chinese culture, in some cases, individuals would talk about mental illness as an imbalance of yin and yang. Okay. So there are a variety of ways of considering cause. Racism and discrimination, also important to talk about. There is, unfortunately, good evidence that suggests that clinicians themselves take in sort of their own cultural lenses, but also their own diagnostic biases. And so we do know that that is the case. And one thing that is going to be sort of sad to read to you, but I'm going to read to you nonetheless, and I've got a link for this in my PowerPoint, and I'm, again, happy to send that to you. This is just the executive summary for a much longer report that came out from the Surgeon General's office in actually 2001. So it's getting quite dated at this point, but they have not done an update at this point. But according to the U.S. Surgeon General, here are 4 themes that came out. 4. Yeah, I can count. 4 themes that came out of this particular research and report. And they just use the term minorities here to talk about racial ethnic groups in particular, because that's what this report was done around. First conclusion: minorities have less access to and availability of mental health services. 2, minorities are less likely to receive needed mental health services. 3, minorities in treatment often receive a poorer quality of mental health care. And 4, minorities are underrepresented in mental health research. And when they talk about minorities in treatment often receive a poor quality of mental health care, the way that that is defined within the report is receiving treatment that actually meets established standards of care. Okay, so we know that there are issues there. We also know that racism and discrimination, that there is a significant correlation with mental illness. Okay. Does that mean that everyone who suffers from racism or discrimination develops a mental illness? No, but there is a correlation there, and I think that's important to recognize. I think it's also important to think about, not even just in terms of anxiety disorders, but also just chronic stress. And so what is the impact of even a lower level chronic stress over time? And one recent thing that has been sort of making the social media rounds, and if you haven't seen it yet, I think is a very worthwhile thing to see, actually was Madison ended up sort of following Harvard's lead on this one, but you can click on this particular link. It will take you to I2M UW-Madison, and here are some of the images, and you may not be able to see these very well, but here are some images from some UW-Madison students putting on a whiteboard some comments that they get directed to them or have had directed to them. So my qualifications got me into UW, not my skin color. Hmongs have become so advanced. No, professor, I cannot speak on behalf of all Latinos. Aren't you the expert? And our student over here, don't worry about money. The government pays for your education anyway. Okay. These are some of the more chronic sorts of experiences that individuals may experience on a daily basis. And in particular, these were speaking to the experiences of persons of color, but when you think about being gay or lesbian, when you think about having a disability, when you think about some of those sorts of issues, similar kinds of experiences can be an issue. And so I think it's just important to be aware of that as well. And then when it comes to protective factors and help seeking, just be aware that different things are seen as sources of support and do act as sources of support. As an example, good research that for African American women, for example, family and spirituality and the strength of those often act as a real buffer against mental illness or can be seen as a coping mechanism. Also important to understand that the way people go about coping can be very different. In an individualistic culture, we tend to focus more on, okay, this is my problem, I've got to solve it, kind of a thing. That may not be the way that it is viewed in all cultures. Some cultures may value a very active approach to, I'm going to identify a problem and work on a problem, where in other cultures self-control and restraint are valued more, where non-interference is seen as a real value. So yes, I have a family member who is struggling in this way, but no, culturally it would not be appropriate for me to insert myself in that situation, because culturally non-interference is the value or the norm. And in terms of help seeking, some of what we have from the research tells us that, for example, persons of color are more likely to delay longer in seeking help for mental illness. Bless you. And so when help is sought, oftentimes that illness is more progressed at that point. I think some of the same bears out for physical kinds of illness. But it's also true that individuals may have different preferences based on culture for traditional healers, counseling, medicine. There may be individuals who come from cultures where talking with someone outside of the family about personal problems would be a taboo. It would be a forbidden sort of a thing. So important to keep that in mind as well. This last slide, honestly, is really to give you resources, and I will send this to you because I want to make sure we have time for questions. There's some great information here in that first link at the National Institutes of Mental Health on different anxiety disorders, their symptoms, all that involves. That second link is actually to this Culture Counts report, which has specific chapters on American Indians, African Americans, Latinos, and Asian Americans and mental health issues. And this particular YouTube link actually talks a little bit about cultural competence and what that means and doesn't mean. So I think that will be helpful. This last link is actually to a specific organization that talks about workplace stress and anxiety and different sorts of things to be aware of in the workplace, as well as strategies for dealing with it in the workplace. So all of those hopefully will be helpful to you.